Okay, this video focuses on coronary circulation, that's blood supply to the heart, nerve supply to the heart, as well as the details of the cardiac muscle. Coronary arteries are the very first branches of the aorta. As you can see here, this is the aorta. These are the branches that originate from the aorta, right in the very beginning of the aorta. Right coronary artery here, left coronary artery here. Okay, so you can see their branches further to cover the entire heart, and that is the same thing shown on the posterior side. There are a number of other names that are associated with these branches, but we will not be focusing on specific details of those branches. All right, with this, let's talk about some challenges we have with coronary circulation. What are these challenges? Well, they're listed here. No functional anastomosis between the two major coronary arteries. Anastomosis are these connections between the vessels. They could be arteriovenous anastomosis, arterial-arterial anastomosis, meaning basically there are little branches that begin from one artery and connect the other artery. The advantage of these anastomosis is that if one vessel were to be damaged or, occluded, then you have at least another artery to keep the blood supply continuously. So that's not possible here. No anastomosis can be seen. And then oxygen extraction from the coronary circulation is much greater. Well, what is that? Let's talk about this a little bit. Typically, when the oxygenated blood leaves the lungs and leaves the heart, it's 100% saturated with oxygen. So in the blood that returns to the heart, that's considered the oxygenated blood, interestingly, it's still saturated with 75% oxygen. It's still saturated with 75% oxygen, meaning only about 25% of the oxygen that left the heart is used up, and we still have this 75% oxygen attached to hemoglobin within the blood that returns to the heart. However, that's not true of blood supply to the heart, because when the blood returns from the heart, it's only 25% saturated. What that means is cardiac muscle tissue uses about 75% of the oxygen in the blood that circulates within the heart. So there is that greater demand for oxygen. That's what we learn from this, okay? Now, yet another interesting point to make is that blood supply to the myocardium, especially the ventricular muscle, put it that way, especially the deeper parts of the heart, is interrupted during systole. Systole is the contraction part of the heart, contraction duration of the heart. So during the contraction of the heart, blood supply ceases. Really? Yes. Yes, because when the muscles contract, the blood vessels that are in this muscle tissue are also constricted. So there is less blood flowing to the deeper parts of the heart, the ventricular portion of the heart, because ventricular contraction is the bigger of all the contractions we see. And in particular, the left ventricular contraction is even more significant. So that's where the blood supply is cut off during systole. You see? Now, yet another interesting fact is that coronary arteries are prone to developing plaques. Plaques are the deposits of fat and other material like calcium, blood clot, and so on. So coronary arteries happen to be one of those medium-sized arteries to be developing these plaques more commonly than some other vessels. All right. Adding all these details like high demand for oxygen, no blood supply during systole, or limited blood supply during systole, and then plaque formation is more common here. This is a bad combination, isn't it? So now let's continue this conversation further. All right, so let's look at the first statement here. About 75% of the blood supply occurs during diastole. Most of the blood supply happens during diastole. Basically, it's the same thing as we talked about before, because during systole, there is constriction of the coronary vessels. This happens mainly during diastole. Okay? Now, what this also tells you is only about 25% of the blood supply occurs during systole. 25% has to be the blood vessels supplying the superficial parts of the heart, and maybe the atria that are not contracting at the same time as ventricles. So those are the parts that are supplied during systole, but not the ventricles because they are in the contracting mode. All right. A branching of the coronary arteries travels the heart from the epicardium to the endocardium. So from the outside to the inside is how the vessels grow into the heart, and therefore the deeper parts are the ones that are affected more. The vessels supplying the subendocardial portion, meaning underneath the endocardium of the left ventricle in particular, are mostly compressed by the myocardium during systole. So the basic detail was talked about earlier also. It is the blood supply from the surface of the heart to the deeper parts. So the deeper parts are affected, and left ventricle is more affected, is what you're hearing again and again. Blood flow is determined by two factors. That is, the amount of time the heart spends in diastole. Greater the amount of time the heart is in diastole, better it is for blood supply. Now that we know diastole is a better time for blood supply, longer the period of diastole, longer the blood supply, or the better the blood supply, isn't it? And the other thing is, like any fluid or a gas, blood moves from higher pressure to lower pressure. During systole, the pressure in the ventricles would be very high. You see, so if the blood is arriving from the outer parts of the heart to the deeper parts, when it arrives in the ventricle during systole, the pressure is so high that the blood supply is simply cut off. Whereas during diastole, the pressure is nothing. So blood would move from the epicardium to the chamber within the ventricle more readily. So those are some details that help us what is required for the blood supply. Low pressure in the deeper parts of the heart, as well as the longer duration in diastole, would help receive more blood supply. Now, subendocardial region of the left ventricle is more prone to ischemic damage. Yes, this is because subendocardial region is the deeper part of the left ventricle, and that is the one with more muscle fibers, and that is the one with greatest pressure. All of those combinations make left ventricle be the one to suffer from decreased blood supply, which we call as ischemia. Ischemia is less blood supply than normal. Okay, so that's the most common site for myocardial infarction. And what we are seeing here in this image is the aortic pressure. I want you to see the pressures ranging from 80 to 120. 120 is around the time when the blood gets pushed into the aorta. So that is when you have the systole. Okay, ventricular systole, it would push blood into the aorta that pushes the pressure to 120. Okay, so now we're talking about blood supply to the left ventricle. Look at it. It is less blood supply during systole, and then when the ventricles are in diastole, so this is systole, so it has to follow with diastole, and that's what we're talking about. So during diastole, there is greater blood flow to the left ventricle. Left coronary artery is shown because that's the one that's responsible for blood supply to the left ventricle. And right coronary artery doesn't have to follow all these rules as rigorously because the pressure changes are not as significant. Okay, so that is what we learned from this slide. Now let's move on to talk about other details related to cardiac muscle and the blood vessel, blood supply, etc. Ratio of muscle fiber to capillaries is 1:1, meaning one muscle fiber receives one capillary. That is, each muscle fiber has its own blood supply. That's how you understand this. This story is the same with skeletal muscle fibers. Okay, so now if skeletal muscle fibers increase their activity, such as during exercise or with regular exercise, skeletal muscle fiber hypertrophy or expansion happens, more proteins, more cellular structures, etc. And that also triggers more blood supply, more capillaries grow in this direction. So the ratio changes in skeletal muscle. It's not going to be 1:1 anymore. I'm just making up a number here, such as 1:10. So in an athlete, skeletal muscle fibers may have a greater ratio than in a non-athlete, all right? But when you think about cardiac muscle, yes, as we use the heart, such as from exercising, etc., a greater workload makes the heart hypertrophy a little bit. And now hypertrophy of the cardiac muscle does not change the ratio of the capillaries. That means the number of capillaries will be constant, whether there is hypertrophy or no hypertrophy. So that could, by in itself, can be a threat for developing ischemia. So an athlete with hypertrophied cardiac muscle fiber but limited blood supply to the heart probably is more prone to developing ischemia, right? Good. All of this may sound a little bit scary, but well, there is good news. Here is that good news. Autoregulation of coronary circulation. What that is there is some internal control that exists within the heart that would adjust the blood vessel size, that is vasodilation, when there is limited blood supply. All right, vasodilation is the expansion of the size of the vessel. How is that possible is what we want to understand here. If there is less oxygen supply, that is like the limited blood supply during systole, limited number of capillaries, limited number of anastomosis, any of this leading to less oxygen than normal, what happens is there is a high amount of ATP that is converted into AMP and ultimately to adenosine. Okay, you're using more ATP energy, but you're not able to make more ATP because you don't have much oxygen to use in aerobic pathways. All right, so with that, we have more adenosine in the local blood circulation. That's an indicator for vasodilation locally. All right, yet another mechanism is when there is less oxygen, that also implies that there is more CO2 buildup, more hydrogen ion buildup. So this combination of events, less oxygen, more CO2 means more hydrogen ions. So they go hand in hand. The mechanism that's involved is too detailed for us to discuss here, but just know that acidic condition can be set because of the buildup of CO2 and buildup of hydrogen ion. All of that could cause vasodilation. All right, so that's good news. Then there are local agents release certain prostaglandins like PGI2 and buildup of potassium and buildup of lactic acid. All of those also could lead to vasodilation. So here is some relief for us. Whenever there is a real shortage of blood supply that leads to decreased oxygen levels locally, that would lead to some vasodilation. So there is that increased amount of blood that flows into the cardiac muscle tissue. All right.